Hi, I'm Jen Ackerson, and in this training video, we're going to break down how to use ASAM criteria to determine the most appropriate level of care for individuals with substance use disorders. Whether you are new to ASAM framework or just need a refresher, this guide will walk you through the key concepts to show you how to apply them in real-world settings. Understanding ASAM placement ensures that clients receive the right intensity of treatment based on their clinical needs. This video will help you navigate the 6 ASAM dimensions, interpret risk ratings, and complete the placement form accurately. We'll also walk through a case example so that you can see the process in action. The American Society of Addiction Medicine, or ASAM for short, criteria is a standardized framework used nationwide to assess and place individuals in the most appropriate level of substance use treatment. This is the third edition that I'm going to be talking about today. The fourth edition is on its way, and for the most part, will generally stay the same with some changes. The ASAM takes a whole person approach considering medical, psychological, and social factors that influence a person's recovery. Rather than using a one-size-fits-all approach, ASAM placement ensures that the treatment recommendations are based on clinical needs, risk factors, and available resources. This helps prevent undertreatment or overtreatment and supports clients in engaging in the right level of care at the right time. Accurately applying ASAM criteria helps therapists, doctors, billing, and the entire treatment team make informed decisions about whether a client needs outpatient services, intensive outpatient care, residential treatment, or medically managed inpatient care. It also helps justify these placements to insurance providers and ensures continuity of care. When ASAM is applied correctly, clients receive care that meets them where they are, leading to better engagement, improved retention in treatment, and greater long-term success in recovery. Frequency is also important to note and changes with the level of care. So everyone gets an ASAM at the time of their admission. They get an ASAM when they transfer between levels of care, either higher or lower, and at time of their discharge. Other than that, IOP ASAMs happen every 60 days, OP ASAMs are due every 6 months, and PHP or partial hospitalization program ASAMs are due every 14 days. Now that we've covered what ASAM is and why it's important, let's dive into the 6 dimensions and how they shape the placement process. The ASAM criteria is designed to provide a comprehensive, multidimensional assessment of a person's needs in substance use treatment. Rather than focusing only on a diagnosis or level of substance use, ASAM evaluates the whole person, considering multiple factors that influence their treatment needs and recovery process. These factors are organized into 6 dimensions, each play a role determining the most appropriate level of care. By assessing each dimension, clinicians can better understand the complexity of a person's situation and make an informed decision about their placement. So the 6 dimensions of ASAM criteria are acute intoxication and withdrawal potential, biomedical conditions and complications, emotional, behavioral, or cognitive conditions and complications, readiness to change, relapse, continued use, or controlled problem potential, and recovery or living environment. So let's start with the first one, acute intoxication and withdrawal potential. This dimension assesses a person's current substance use and withdrawal risks. It evaluates whether they are experiencing or at risk for withdrawal symptoms, substances they have been using, and whether medical supervision is necessary to ensure their safety. We want to be extra careful for individuals using alcohol or benzodiazepines, as withdrawal from those at a higher level of use can be fatal and generally needs medical supervision. So for example, someone actively experiencing alcohol withdrawal with a history of seizures would likely require a higher level of care, such as a medically managed withdrawal program. On the other hand, if somebody has mild withdrawal symptoms that can be managed in an outpatient setting, a less intensive level of care may be appropriate. The second dimension, biomedical conditions and complications, looks at a person's physical health and medical conditions that may impact their treatment. It considers whether they have chronic illness, unmanaged medical conditions, or physical impairments that require medical attention. For instance, a person with untreated diabetes or chronic pain might need integrated medical support while engaging in substance use treatment. If their medical needs are stable and do not interfere with their ability to participate in treatment, a lower level of care might be sufficient. The third dimension is emotional, behavioral, or cognitive conditions and complications. This dimension focuses on mental health conditions and cognitive functioning. It assesses whether the person has co-occurring mental health disorders such as depression, anxiety, PTSD, schizophrenia, and whether these conditions are stable or require specialized treatment. It also considers cognitive impairments that could impact their ability to engage in treatment. Someone with severe unmanaged mental health symptoms such as active psychosis or suicidal ideation may need a higher level of care that includes psychiatric support, while someone with stable depression or anxiety might do well in outpatient treatment. The fourth dimension is readiness to change. This dimension evaluates motivation and willingness to engage in treatment. Not everyone entering treatment is ready to change, and this can impact their success in different levels of care. Some individuals may acknowledge that they have a substance use problem and be eager to participate in treatment, while others may be ambivalent or resistant. If a person is highly motivated, they may benefit from a lower level of care with strong outpatient support. If somebody is resistant or lacks insight, a more structured setting may be needed to engage them in the recovery process. The fifth dimension is relapse, continued use, or continued problem potential. So this dimension assesses risk of ongoing substance use and relapse potential. It considers past relapse history, current cravings, coping skills, and external pressures that may contribute to continued substance use. If a person has significant difficulty maintaining sobriety, lacks coping mechanisms, or has relapsed multiple times in lower levels of care, they may require a higher level of treatment with increased supervision and structure. Conversely, somebody with strong relapse prevention skills and support may be able to succeed in outpatient care. And the sixth one is the recovery or living environment. And this dimension looks at external factors that may support or hinder recovery, including housing stability, family dynamics, and social environment. If a person lives in an environment that actively supports substance use, such as people who are still using, they may need a higher level of care or supportive housing to maintain recovery. On the other hand, somebody with a stable home, positive support system, and access to resources may do well in a lower level of care. So, by evaluating all six dimensions together, clinicians can build a full picture of a person's needs and determine the least restrictive yet most effective level of care. The goal is to balance safety, treatment engagement, and real world circumstances, ensuring that individuals receive adequate support without unnecessary overtreatment. For example, if a person scores high on dimension 1, so that was the acute intoxication and withdrawal potential, but low on the others, they may need temporary medical stabilization before transitioning to a lower level of care. If a person has severe mental health symptoms in dimension 3 and unstable living environment in dimension 6, they may need residential treatment to provide structure and stability. The ASAM criteria ensures that placement decisions are individualized, considering the complexity of each person's situation rather than applying a one-size-fits-all approach. Now that we've covered the six dimensions, let's explore how these assessments translate into actual level of care placements. So once we've assessed a person using the ASAM criteria, the next step is matching them to the appropriate level of care. ASAM organizes treatment into a continuum of care, ensuring that individuals receive the least restrictive but most effective treatment based on their clinical needs. This means that treatment is not a one-size-fits-all approach. Some individuals may benefit from outpatient care with minimal structure, while others require intensive 24-hour medical supervision. Each level of care differs in the frequency of services, medical oversight, and structure provided. I'm just going to break down the primary levels of care, what they include, and when they're most appropriate. So starting with level 1, outpatient, or we call it OP, JADE offers this. So what it is outpatient treatment is the least restrictive level of care. It's designed for individuals who are medically and emotionally stable, have a low risk of withdrawal, and can maintain their daily responsibilities while receiving treatment. So who is it for? It's for individuals with mild substance use issues who need structured support but not daily treatment, people who have completed higher levels of care and need ongoing therapy to maintain their recovery, and those with strong social support systems and minimal risk of relapse. What's included in this level of care is generally 1 to 2 sessions a week, often one group therapy session and one individual session a month, medication management if needed or wanted, and psychoeducation on relapse prevention, coping skills, and stress management. And support groups like 12-step programs or peer recovery meetings are encouraged but not required at JADE. Other outpatient treatment centers might require that a person attend these outside of their regular treatment. We usually just say like, hey, the goal of treatment is that you get well enough that you don't need us anymore. And part of that is having a support network outside of JADE. So however you want to build, that's up to you. So an example of this might be a person who has completed intensive outpatient treatment, IOP, and that's the one we're going to talk about next, and is doing well in recovery, but still benefits from monthly check-ins with their therapist. So next up is intensive outpatient program level 2.1, also known as IOP. And JADE does this one too. So IOP is a step up from outpatient care, offering more frequent therapy and structured support while still allowing individuals to live at home, continue with work, school, or other responsibilities. It's for individuals who need more structure and accountability, but don't require 24-hour supervision. Those at moderate risk of relapse who need skill building and ongoing support, and people transitioning from higher levels of care who still need frequent counseling. What's included is generally 3 to 5 therapy sessions per week, totaling at least 9 hours of treatment, a combination of individual and group therapy focused on relapse prevention, emotional regulation, and behavioral changes, access to psychiatric services for medication management, and also medicated assisted treatment, family therapy, and support for co-occurring mental health conditions. So an example of this might be for a person who has relapsed after outpatient care but doesn't need detox or residential treatment. The next one we're going to talk about is Partial Hospitalization Program, level 2.5, also known as PHP, and JADE is also licensed for this one. So PHP, or also sometimes called day treatment, is a step below inpatient care, but it still provides intensive structured treatment during the day while allowing individuals to return home or in a supportive living environment at night. So that partial hospitalization word can be a little bit misleading for new clinicians and even for clients when we're pitching this idea to them. It doesn't mean that they're staying in the hospital. It just means that they're here all day, every day. So, who it's for is individuals who need more structure than IOP but are stable enough not to require 24/7 inpatient care. Those with moderate to severe substance use disorders who need medical monitoring but don't require hospitalization. So, again, the name's a little misleading. And people with co occurring mental health conditions that require intensive therapy, more intensive than the intensive outpatient. Remember, intensive outpatient was 9+ hours of therapy. PHP is 20+ hours of therapy per week. So, that's really the big difference here. It's often daily group and individual therapy sessions. Usually it's 2 groups a day and at least individual therapy once a week. There's psychiatric support once a week and medication management once a week, crisis intervention services if needed, structured support for daily life skills, coping strategies, and relapse prevention. There's also family therapy and education. So an example here would be a person who's medically stable but struggling with relapse triggers, emotional regulation, or untreated mental health issues that interfere with daily life. And the next section here is residential or inpatient treatment. So that's going to be levels 3.1, 3.3, 3.5, 3.7. And I'm just going to talk about all of them on this one slide right here. So residential treatment offers 24-hour structured care in a facility where individuals receive round-the-clock supervision, medical support, and intensive therapy. The level of intensity based on the severity of the individual's needs. So this is usually called inpatient treatment too. Residential and inpatient are just used interchangeably. And all of these can get a little confusing to suss out, but just remember the bigger that the number gets, the more treatment and the more care is offered. So starting with 3.1, clinically managed low intensity residential. So it's for individuals with chronic relapse issues, unstable home environments, or difficulty maintaining sobriety without a structured setting. So if we're thinking about ASAM dimensions, we're really looking at dimensions 5 and 6 here. So what's included is 24-hour supervision, low intensity therapy, peer support, and life skills training. So somebody transitioning from intensive treatment who still need a sober living environment before returning to full independence. So this one you might also just call like maybe a halfway house. So an example of this program would be the Greenbrier Treatment Center. So this is in Washington, PA. Greenbrier offers a halfway house program that provides a structured support environment with low intensity therapeutic services, focusing on relapse prevention and life skills development. Level 3.3 is population specific high intensity residential. It's for individuals with cognitive impairments or behavioral health issues that require a slower paced modified treatment approach. Similar to 3.1, but more specialized support for cognitive or mental health conditions. So again, we were thinking about dimensions 5 and 6 in the last one. We're going to think about 3, 5, and 6 for this one. So a person with traumatic brain injury or neurocognitive deficits or needs a highly structured residential setting. So examples of this one could be the Powerhouse, and POWER stands for Pennsylvania Organization for Women in Early Recovery. So this is in Pittsburgh, and Powerhouse provides a gender-specific residential treatment tailored to women, including those with cognitive impairments or co-occurring disorders, right? So this is all dimension 3, offering a slower paced supportive environment. And a similar program to that also in Pittsburgh is Sojourner House, and that one's a 6-month residential treatment program for women to live with their children together and receive treatment together. So neither of these programs are doing detox or round-the-clock medical support. So think of it as more as a long-term therapeutic living environment, right? So if we're looking at dimensions 1 or 2, these wouldn't quite meet the needs for that yet. Moving on to level 3.5 or clinically managed high-intensity residential. This is for individuals with severe addiction, multiple relapses, and co-occurring disorders who need intensive therapy and structure. This is going to be daily therapy, relapse prevention, planning, case management, medical monitoring. So a person with severe opioid addiction and mental health instability who has failed in outpatient settings. So we're going to look at dimensions 3, 4, 5, and 6 for this one. An example of this program would be like the Pyramid Healthcare in Pittsburgh. They have a residential treatment center in Wilkinsburg. And Pyramid Healthcare offers high-intensity residential treatment for individuals with severe substance use disorders and co-occurring mental health conditions. Their program includes daily therapy sessions, medical monitoring, and comprehensive support services, and it's about 28 days long. And then the last one in this residential inpatient level 3 section is 3.7, or medically monitored intensive residential. It's for individuals with high-risk withdrawal symptoms, unstable medical conditions, or psychiatric needs that require close medical monitoring. So now we're talking about dimensions 1, 2, and 3. Included is 24/7 medical oversight, detox services, and intensive behavioral therapy. So a person experiencing severe alcohol withdrawal who needs medical supervision, but not full hospitalization. An example of this could be like Gateway's Rehab Center in Aliquippa. So Gateway provides medically monitored intensive inpatient services, including 24/7 medical supervision, detox, and intensive therapeutic interventions for individuals with significant withdrawal risks or medical complications. So again, we're looking at dimensions 1, 2, and 3. We're also considering 6 quite a bit too for any of the residential or inpatients. We want to look at making sure that the residential treatment can provide support for them. And then the last level is level 4. So this is talking about medically managed inpatient treatment. This is also known as detox and hospitalization. So it's the highest level of care. Level 4 provides round the clock medical and psychiatric care in a hospital setting for individuals with life threatening withdrawal symptoms, acute medical needs, or severe psychiatric instability. So to meet criteria for one of these, the clients would have to have some significant needs in dimensions 1, 2, 3, 4, 5, and 6. So it's for individuals experiencing life-threatening withdrawal. So think delirium tremens or seizures, those with severe co-occurring mental health conditions that require immediate stabilization, people with complex medical conditions that cannot be safely managed in a lower level of care. So think like untreated diabetes, they've got to be established on insulin in addition to detox at the same time. What's included is 24/7 medical and psychiatric care, medically supervised detox, crisis stabilization, and intensive monitoring, preparation for step down care. So usually when somebody starts at a level 4, they'll step down to a level 3, step down to a level 2, step down to a level 1, and so on and so on. They don't just stop at level 4 and just be done with it. Examples of hospitals that offer this level of care is Butler Hospital, UPMC Mercy's Addiction Medicine Program, UPMC McKeesport, and UPMC Western Psych Hospital. An example of this would be for a person who's experiencing seizures from alcohol withdrawal and requires IV fluids monitoring and hospital care. So matching a person with the correct level of care is crucial in their success in treatment. If a person is placed too low, they may not receive the structure and support that they need to stay sober. If they're placed too high, they may disengage from treatment or struggle with unnecessary restrictions. The ASAM criteria ensures that individuals receive just the right amount of support, medical care, and therapy to maximize their chances of success. So now that we've covered the different levels of care, let's take a closer look at how risk ratings and placement decisions work together to determine the best treatment path for each individual. Determining the appropriate level of care involves more than just identifying a person's substance use history or diagnosis. The ASAM risk rating system helps clinicians assess the severity of individuals' needs across the 6 ASAM dimensions, allowing for a more nuanced and person-centered approach to treatment placement. The system ensures that treatment recommendations are based on actual clinical risks and strengths rather than a one-size-fits-all model. The risk rating system uses a 0 to 4 scale where each dimension is assessed independently to determine the person's level of need. So 0 would be no risk. The individual is stable with no immediate concerns. They're functioning well in this dimension and do not require intervention beyond routine care. So an example of this would be a person with no withdrawal symptoms, no medical complications, has a stable home environment, and strong support system. 1 is mild risk. There are minor concerns that require attention, but they can be managed at a lower level of care with minimal intervention. So an example would be somebody with occasional cravings, but strong coping skills, or a person with controlled medical condition that does not interfere with treatment. 2 is for moderate risk. The individual needs structured support to maintain stability, but their condition does not warrant 24-hour care. They may need a higher intensity outpatient setting or partial hospitalization to ensure safety and progress. So a person experiencing mild withdrawal symptoms that can be managed in an outpatient setting, or someone struggling with early recovery who benefits from IOP or PHP. 3 would be severe risk. Person requires a high level of intervention to prevent harm or deterioration. Without residential treatment or medically monitored care, the risk of relapse, medical complications, or emotional distress is significant. So an example of this would be somebody with unstable mental health conditions, frequent relapses, or severe withdrawal risks that require residential treatment. So think level 3.5 or level 3.7. And then 4 is very severe risk. The individual is in immediate danger and requires intensive round-the-clock medical psychiatric care without immediate intervention. They face life-threatening withdrawal, self-harm, or severe medical instability. So the example here is a person with severe alcohol withdrawal, having seizures, acute suicidal ideation, or a medical emergency requiring hospital-based inpatient care. We would think of level 4. So notice how the risk rating really matches with the levels of care offered. 1 is more outpatient, 2 is more IOP or PHP, 3 is more of that inpatient residential, 4 is hospital-based. So you want to start considering the risk level of the clients that you're seeing. If they're very high risk, we would want to think of something more intensive in the level of care that's recommended. But risk ratings don't automatically determine the level of care. So take what I said, and it's just going to be a nugget of a thought in the back of your brain. So it's important to understand that high risk ratings in one dimension don't automatically mean placement in the highest level of care. A person might score a 4 in dimension 1 in withdrawal risk, but only needs short-term medical detox rather than full hospitalization. Similarly, a low risk rating in one dimension does not mean a person is ready for outpatient care. Placement decisions are based on the overall assessment of all 6 dimensions. So when you're doing an ASAM, you're probably going to have like a 4 in one place, a 3 in one, a 2, a 0. You're going to have a mix of all of these numbers all over the place. So you want to look at the whole picture, not just, ooh, we've got 1 4. It means we go to the hospital. Or, ooh, we've got 1 0. It means no treatment's recommended. So for example, a person might score a 3 for relapse risk and a 2 for biomedical conditions, But if they have a strong social support, 0 in dimension 6, they're highly motivated, 1 in dimension 4, and they might thrive in IOP or PHP rather than residential care. Conversely, if somebody with a 1 or 2 in withdrawal potential but a 4 in emotional stability and living environment due to unsafe housing and severe depression, they might need residential treatment despite not requiring detox. Clinicians use clinical judgment, ASAM guidelines, and a person-centered approach to weigh risk levels across dimensions and determine the least restrictive, most effective level of care. The goal is to provide enough structure and support to meet the client's needs while avoiding overplacement in settings that might feel unnecessary or discouraging. So now that we understand how risk ratings influence placement, let's walk through how to complete an ASAM placement form and document these decisions effectively. So filling out an ASAM placement form is a critical step in ensuring that the client receives an appropriate level of care based on their individual needs. This form serves as documentation for treatment recommendations and is often required for insurance authorizations, clinical decision-making, and continuity of care. At JADE, there is a cheat sheet available in CareLogic that can help guide you in what to write in the narrative sections of the form. The cheat sheet can be accessed by searching under Test Client or entering client number 2572, and their birth date that you want to look for is 1/1/1990. And the most recent ASAM dated July 12, 2022, provides an example of how to structure the documentation, and I just have a screenshot of it on this page so you know what it looks like. But to determine the correct criteria indicated, you have to refer to one of the ASAM binders on site at JADE for guidance. So step 1 is you're going to choose the type of ASAM form. The first decision completing the form is choosing the correct type of ASAM that we're doing. So there's 3 different types: admit, continued stay, transfer, discharge. So admit is used when a client is entering treatment at a specific level of care. This means that they meet the criteria for that level of care based on ASAM dimensions, and they've not been previously receiving treatment from anywhere else. So if you have somebody coming in seeking IOP and they haven't done any other substance use treatment, that's an admit ASAM. But if they're coming from a 3.7 residential treatment and they're seeking IOP as follow-up care, that would be considered a step down, and that would actually be a transfer. So we'll talk about that on a second. So admit ASAMs are for people who are maybe just coming in off the street. They haven't been to substance use treatment recently. The next one is continued stay. So that's used when a client is already in treatment and just needs a little more time at the current level of care. So this form should justify what the client has not yet met as far as treatment goals and what still requires support. So for instance, if they're in IOP and they need more time in IOP, you're doing a continued stay ASAM for IOP. And then transfer or discharge ASAMs are used when a client needs to move to a different level of care, either higher or lower, that's the transfer, or has successfully completed treatment and is ready for discharge. So that's the discharge one. And this form should just clearly justify the change based on ASAM dimensions. And it gets a little confusing when a client ghosts us. Maybe they didn't successfully complete, but we're going to discharge them from our system. Likely their ASAM then would be considered a continued stay because we'd be recommending continued treatment for them. So it wouldn't be a discharge ASAM despite discharging them from the system. The discharges are for successful discharges. Transfers are for higher or lower levels of care internally or externally. So again, a client coming from residential treatment 3.7 who's seeking IOP would be a transfer ASAM. This step just ensures that the form aligns with the client's treatment trajectory and that the appropriate justification is provided. And in the ASAM binder that you're going to find on site, all of the ASAM cheat sheets are built out of either admission criteria, continued stay criteria, or transfer discharge criteria. So there's basically 3 different types of ASAMs that you can ever choose from at any point. Step 2 is to assess each ASAM dimension and document findings. So the form is structured to document findings for each of the 6 ASAM dimensions. Clinicians should carefully assess the client's risk and needs using the risk rating system 0 through 4 to determine the severity in each area. The ASAM cheat sheet in CareLogic can guide you to what to write in the narrative, but the ASAM binder must be used to determine if the criteria are met. So I'm just going to talk briefly about what to write in each dimension. So dimension 1, acute intoxication or withdrawal potential. Describe any withdrawal symptoms, need for detox, or history of severe withdrawal complications. If stable, document that as well. So an example to write here would be client reports last opioid use 3 weeks ago, no current withdrawal symptoms present, no history of complicated withdrawal, is being supported on medication for opioid use disorder. In 2, biomedical conditions and complications, you want to identify any chronic health conditions, physical injuries, or medical needs that might impact treatment. So you might say client has hypertension controlled with medication, no current medical complications that interfere with treatment. 3 is emotional, behavioral, or cognitive conditions and complications. So describe mental health symptoms, psychiatric diagnoses, and stability of any co-occurring conditions. So an example here would be client has a history of generalized anxiety disorder, currently managed with therapy and medication, no active suicidal ideation. 4 is readiness to change. So you're assessing for the client's motivation for treatment and their engagement level. An example here would be client acknowledges opioid use has negatively impacted relationships and employment, but is ambivalent about stopping completely, willing to gauge an IOP to explore options. And this would be a place where, if you're familiar with stages of change, you can also assess stage of change. So from this little blurb that I just said, you would probably consider like, oh, it seems like maybe pre-contemplation stage of change. 5 is for relapse, continued use, or continued problem potential. You're going to describe relapse history, cravings, and risk factors that impact recovery. So an example here would be client reports 3 previous treatment attempts, most recent relapse occurred after losing housing, identifies stress as a primary trigger, and lacks structured coping skills. And the last dimension, 6, is for recovery or living environment. So you're going to assess housing stability, social support, and environmental risks related to recovery. So an example would be client resides in sober living housing with supportive peers, reports stable employment, and plans to transition to independent housing within 60 days. Step 3 is you're going to want to use clear and concise documentation. So when filling out the narrative sections, it's important to be factual. Stick to observed behaviors and reported symptoms. Be concise. Provide enough information to justify the placement, but avoid excessive details. You want to use clinical language. Describe symptoms and behaviors in professional, objective terms. So some language suggestions would be, instead of client has severe depression and is really struggling, you would say something like, client reports symptoms of major depressive disorder, including low energy, poor concentration, and anhedonia, which impact daily functioning. Or instead of client relapsed because they got stressed and freaked out, you would say, client experienced a relapse following high stress event, citing difficulty to utilize coping skills during moments of distress. Step 4 is avoiding common documentation errors. So again, we don't want to include too much personal detail. Keep the documentation clinically relevant rather than telling a long personal history. I usually aim for 2 to 3 sentences per narrative in each dimension. You also want to avoid being too vague. Avoid phrases like client needs help without explaining why. We also want to avoid making assumptions. Only document what has been reported or observed rather than personal opinions. And we want to avoid incorrectly justifying placement. Make sure that criteria indicated match the ASAM guidelines from the on-site binder. So we're not going to say, oh yeah, this person's stable in every dimension all the way down, but they need to go to 3.7. Like that's just not going to fly. And then the final step is to review and submit the form. So before submitting, double check that the correct ASAM type is selected, so admission, continued stay, or transfer discharge, that each dimension has a narrative explanation that supports the risk rating, the criteria indicated is accurate based on ASAM guidelines, and documentation is concise, professional, and clinically relevant. Once completed, the form should be signed and submitted, ensuring that the client's level of care is clearly justified in their chart. The documentation is crucial for treatment planning, insurance approvals, and clinical accountability. So now that we've covered how to complete the ASAM form, let's walk through a real case example to see this process in action. So we've got sample client, his name's John Doe. Couldn't think of anything more creative. He's a 35-year-old male with a history of opioid use disorder and alcohol dependence. He reports a recent relapse after 6 months of sobriety. He's currently living with a friend who also uses substances and lacks consistent employment. He experiences severe anxiety and depressive symptoms, which worsen when not using substances. He has chronic pain from an old back injury, which sometimes self-medicates with opioids. And he feels really motivated. He knows that he can stop and he wants to stop. He's really ready for some change. He just recognizes he can't do it on his own. So I want you to pause the video here and open a new ASAM in Test Client in CareLogic and do your best to just try on your own. And when you've gotten as far as you think you can get, just unpause me and let's see if we match. Ideally, we would want to recommend the same level of care to be able to match. All the stuff in between is a little bit more subjective. So pause the video now. So you can see that I have Test Client pulled up here, and you can search for Test Client up in this client search, and you can just type in Test Client or Test or Client. You'll get all kinds of options, or you can use that unique client identification number, which is 2572, to search for them. So what we're going to do is we are going to open a new ASAM for this person. And I have it listed underneath my favorites because I use it all the time. But if you don't have it under your favorites, what you can do is you can use that client dropdown. It lives in a couple different places. I think this one's the easiest to find. So client dropdown, intake/assessment, and then ASAM. And then if you just click that star so that it turns like a darker purple, like transfer to program is for me, if you click it, it'll show up under your favorites. So all you're going to do is click to open. And you can see that that one that I was talking about already lives in there from July 12th, 2022. And that can be your guide if you want to open up another tab or another screen and follow along. It's going to ask you questions in each dimension's narrative that you can feel free to write about in there. But what we're going to do is we're just going to go back to that main page and we're going to click Add an ASAM Criteria. So again, we're focusing on John Doe. So you want to make sure that your name is under the dropdown. UCN is unique client number. So that's that 2572 right here up in parentheses next to their name, and then you want to click the date that you're doing the ASAM. So for me, it's February 13th, 2025. And our type of ASAM, do we remember about John Doe? Was he an admission, continued stay, or transfer discharge? No, I don't believe that he mentioned anything about coming from a higher or lower level of care. He was just coming in. So we would call that an admission. So we can skip this part for now because it might be the last part that we would find out as long as we're doing this. But we'll leave this in for now. Is that when you open a new ASAM, it's going to copy forward whatever is in an older ASAM there. So what you can do is you can just go through and delete this because we're not going to need it. But these are all the questions from that July 2022 ASAM that I created in here. So what I have it set up to be is, let's scroll back up to the top. We want to go dimension by dimension. We're going to start with this part first, and then we'll go back up to the top. So we're going dimension by dimension. We're going to start with the narrative part. We'll go to risk. We'll go to criteria, and then we'll go to level of care. I think working backwards when you get started is a little bit easier than going top down until you're really familiar with the ASAM criteria. So for dimension 1, that's intoxication and withdrawal. Not always going to be the same. Dimension 1 is always intox and withdrawal. What would you come up for as far as the narrative to write here? Remember, he's got a recent relapse after 6 months of sobriety. He's using opioids and alcohol. I might say something like this. John reports using heroin and alcohol daily for the past 2 months. His last use was 24 hours ago, and he's starting to feel early withdrawal symptoms, including sweating, nausea, and anxiety. And again, all this information is going to come from that needs assessment. He has a history of withdrawal seizures from alcohol detox. So again, if he has a history of withdrawal seizures, that tells us, okay, he's probably pretty high risk. So we're going to do something, I would say either severe or significant here would be pretty safe. I'm going to err on the side of caution and just say severe. And so the justification here is due to withdrawal risk, John requires medically monitored detox to ensure safety. And I'm just going to click that for here now in this dropdown. So we're going to go to 4 medically monitored or medically managed intensive inpatient. And again, what you're choosing in these level of care dropdowns don't have to match. So it doesn't mean that dimension 2 also has to be a level 4. It's okay. We can just kind of pick and choose depending on each dimension and then go back and look at what might overall be the best level of care fit for him. And this criteria indicated this is going to come from that ASAM binder. So you're going to look at admission criteria for this level 4 care. So it's meets. Or you can also write met if you want. That's, up to you. Either way, he meets criteria. Moving down to dimension 2, biomedical conditions. So John has chronic back pain, but has no acute medical conditions. He has no primary care doctor and occasionally uses opioids to manage his pain. So, in the treatment plan, we would probably look at making sure that he gets in contact with the primary care doctor, or maybe we want to use CRS services to help him do that. But for now, there's nothing really biomedically standing in his way other than the history of seizures from alcohol. And so I might still put him at like a 2 moderate here just because his chronic back pain and his opioid use tend to go together. So while he has that manageable medical condition, his lack of medical oversight and potential for misuse for those opioids for pain management necessitate a structured treatment environment with medical monitoring. So that could be residential, but I think that we could also meet those needs in an outpatient setting if we could get him set up with a PCP. So we're saying moderate. He meets criteria for level 2.1 intensive outpatient. So I'm going to click that one on the drop down. Moving on to dimension 3. So here's what I wrote for my narrative. John reports severe anxiety and depressive symptoms, including occasional suicidal thoughts, without a plan. His mental health has worsened since relapsing. He has never been formally diagnosed or received psychiatric care. So what would you say about a risk assessment here? Again, this just kind of copied forward from my other ASAM that I created a couple years ago. Would you say that sounds mild, moderate, significant, severe, maybe none at all? For me, I'm thinking it sounds pretty significant. Mental health has worsened since relapsing, never formally diagnosed, received psychiatric care. We've got some suicidal thoughts here. Like, we should probably get this looked at a little bit closer by a psychiatrist. So again, we want to look at the lowest level of care that can meet his needs. Can he get his needs met residential? Absolutely. Can he get them met in a lower level of care too? So we're going to look at those 3s are those residentials. Could he get psych needs met in partial? Absolutely could. Could he get psych needs met in intensive outpatient? Absolutely he could. So I'm going to choose that one. And then I'm going to flip open my ASAM binder for admission in dimension 3 to intensive outpatient. And he would either meet that or you would want to identify co-occurring capable A or B. So when we're talking about psych care, we're going to look at co-occurring capable, and Jade is co-occurring capable. So I'm just going to move this over. And I think that he would best meet criteria for co-occurring capable B. And again, you can read through that in the binder when I'm trying to follow along. So we've got dimension 3 done. Moving on to dimension 4, or readiness for change. So again, he was a little ambivalent about it, but he seemed pretty open, pretty motivated here. So I'm just going to say John acknowledges his substance use is problematic. but is ambivalent about stopping completely despite noticing a desire to do so. He expresses concern about withdrawal. And again, for risk assessment, I found a little bit more moderate to me, right? He hasn't been able to really take some steps on his own yet. He's not action stage of change. He's certainly not maintenance. He sounds like he's in relapse stage of change. And if you are comfortable with assessing stage of change, you could also put them in this dimension 4 too. So I might say something like John's appearing to be in the contemplation or preparation stages of change. And for right now, it's not super important that you are really able to differentiate between the two. You're just trying to give the insurance company a juice to admit him into a level of care for treatment. So we're here. We've looked at a moderate risk for this one. Again, I think that we can meet the needs in 2.1 intensive outpatient. For this specifically, we can work on building motivation for change in outpatient. He doesn't necessarily need residential for that here. So the criteria indicated you would either do A or B or co-occurring capable A, B, or C. So again, because we're looking at psych needs in dimension 3, we're probably going to just continue on to say co-occurring capable, and then you need to see if it meets criteria for A, B, or C. For me, this is sounding again a little more like B, but again, it's a little bit subjective here, depending on how much information John has given you in the assessment. And because we don't really have all the information, we're just making this up as we go along. For right now, B is good enough. Dimension 5, relapse potential. What do we know about John and his history of relapse? He's told us a little bit about it already. So I'm writing, John has relapsed multiple times after short periods of sobriety. He struggles with coping skills and has no clear relapse prevention plan currently. So we might even say something like an assessment of, John appears to be high risk for relapse without intervention. So if we're at a high risk, it's probably not mild or moderate. It's definitely not none. It's probably more like significant or severe. I'm thinking high risk sounds pretty significant to me. We're not sure he's going to relapse, but the risk is significant. So that's sounding a little bit more like a residential treatment to me. So one of the 3s in levels of care. And we'll say, it might really be nice for him to have something a little bit more long-term, like a 28-day residential instead of a 5-day. When we're talking about patterns of relapse and short periods of sobriety, we want to make sure that we're giving him the foundation that he needs. So that might sound a little bit more like a longer period of time versus a shorter period. So I'm going to say 3.7. And again, you're going to want to look at the ASAM binder. I actually don't have in front of my face right now. And this criteria indicated ARB was admission criteria to 2.1. I'm pretty sure somebody should probably take a look at that binder right now and tell me about admission criteria to 3.7 in dimension 5. I'm pretty sure it would be needs. I can almost guarantee it. If I was doing this for a real client, I would have a binder in front of my face. This last dimension, recovery environment. John lives with a friend who actively uses substances and does not have stable employment. He has no sober support system and is financially unstable. And while we're here, I just want to show you the save progress box. So we know that hitting submit will save it and move us onto the next page on this left-hand column or the wizard over here. Save progress will do something similar without moving us forward. So sometimes it's just in your benefit to save progress more often than not. And hitting submit sometimes can get a little funky to do a save because I don't really want to be on this page. I don't want to be on this page. So we're all the way down here. What's the risk assessment here? He's living with somebody who's actively using, he doesn't have stable employment, he has no sober support system, and he's financially unstable. That's pretty significant to me. So again, we're going to look at something a little bit closer to like a 3.7 because of the significance of the recovery environment. We need to build him some support in the recovery environment. So again, you want to pull out that ASAM binder, you want to look at admission criteria for 3.7 in dimension 6. And usually it's going to list things out like A or B or C. I don't remember that one off the top of my head, but again, if John were a real client and this was a real ASAM, I'd have a binder in front of me right now. But I'll just take a guess that it's going to be B. And somebody should, again, double check me, make sure I'm just not making stuff up. So again, we're looking at how his home environment actively promotes relapse, but he lacks the stability needed for lower level of care. So a higher level of care is going to be recommended. So now we're going to look at 1, 2, 3, 4, 5, and 6 all together, right? And we've got a 4 up here because of seizures. We've got 1, 2.1, 3.7, 3.7. And we're also looking at these risks too. We got a 3, a 3, a 2, a 3, a 2, a 4. So based on John's overall risk profile, he meets the criteria for level 3.7 medically monitored intensive inpatient treatment. And this level provides 24/7 medical supervision to manage opioid and alcohol withdrawal safely. So they're going to help treat that seizure disorder. They've got integrated mental health treatment to stabilize his severe anxiety and depressive symptoms, got structured intensive therapy to address his relapse history and coping deficits, and a safe drug-free environment, removing him from high-risk living situation. So they're really tackling dimensions 1, 3, 4, 5, and 6. If he had some significant issues in biomedical conditions, that's when we would be looking at 4 more likely. But the seizures can be monitored in 3.7. So I'm just going to change that right now as we're looking at this as far as like a bigger picture here. So while he doesn't require that level 4 hospitalization, he does need a high level of structure and monitoring, which makes him level 3.7 the most appropriate placement for him. So what we would do right now is we're going to go back up to the top and we're going to make sure that all of this reflects our clinical decision-making that the worksheet down below helped us figure. So level of care recommended is going to be 3.7. That's what we're going to say to him. Hey, John, I really think that you would benefit from some inpatient services. Indicate level of care received. Now, this one's a little bit tricky because he's an admission. He has not previously received a level of care. So that's going to be not applicable right now. If he was coming from somewhere else, like say he was like, yeah, I tried outpatient, it didn't really work, I relapsed, and now I'm here to figure out what else I can do, then we would say he's coming from outpatient, he's recommended for 3.7, but because he's not coming from anywhere and he hasn't previously received anything, we're going to say NA. And now we've got this drop down. If these two levels of care are different, you have to justify why. So we're going to say provider judgment, right? The ASAM helped us figure out that he's most appropriate for a 3.7. And then we're going to say indicate program or facility referred to. I'm just going to leave that blank for right now because JADE doesn't offer a 3.7. So we're obviously not going to be referring him to JADE. We're going to give him a list of referrals and talk to him about the pros, the cons of each and help him make a decision on it. And then we want to indicate level of withdrawal management. So again, he needs 3.7 specifically for this withdrawal dimension. So we're indicating that here. And then I always click not applicable as far as referral validation until we really know who we would necessarily be sending this to if we're sending it to them. So as far as this goes, we've got all of these boxes checked out. This is all completed, right? We want to pay attention to any pink box is a required box. The risk assessment is also required, but it's, not the end of the world if you forget that one. So I'm just double checking. We've got all of these completed. I'm going to submit. You can use your electronic signature. So usually that's a 4-digit PIN. I'm going to sign it with my secret password. And then the next staff to sign is going to be Dr. Allen. If you've taken that 2-part ASAM training already, so this training doesn't count for that. It's a different 2-part training. If you haven't taken that yet, you're going to send it to me for a second signature. I'll look over it and make sure it all looks good. If it doesn't, I'll unsign it. I'll send it back to you and say, hey, could you change this part? And then once it looks good, I'll sign it and I'll send it to Dr. Allen. So that's basically what an ASAM is. And then you just hit submit at the top. No, I don't want to save my password. And here it is right back in that original view here. So that's ultimately the conversation that I'd have with John at the time of assessment. I'd be giving him referrals to places that offer 3.7 and take his insurance. And if he is willing to go, great. If he's not, then we have to figure out the least restrictive option where we could admit him on an outpatient basis. But because of the super high risk as far as seizures and not having a PCP to help monitor the chronic pain, I'd be recommending partial hospitalization instead of 2.1, really because of the seizures. I might even be looking at like a 3.5, just like maybe like 5 to 7 day medical detox or an ambulatory detox that is hospital-based before we really get him into outpatient treatment and never feel comfortable admitting a client to treatment, knowing that there's a seizure in the mix. So again, just when completing that ASAM form, you want to make sure that the following are documented: the risk ratings, the justification for 3.7 placement or any placement for any level of care. And you're going to want to use that clear, concise language, emphasizing safety concerns, withdrawal risks, and the need for structured support. And once that form's completed, I showed you, you sign it, I sign it, Dr. Allen signs it. If you make a mistake and send it to the wrong person, we'll catch it, we'll find it, we'll get it to Dr. Allen. Don't worry. Now that you know how to do the ASAM assessment and fill out the form, I want to talk to you about that golden thread. So it's connecting the evaluation to the psychosocial assessment, to the ASAM, to the treatment plan. One of the most critical aspects of completing the ASAM placement form is ensuring that it aligns with this golden thread idea. And that's that seamless connection between all parts of the client's experience. This ensures that clinical decisions are cohesive, well documented, and defensible in both client care and insurance justification. More importantly, it keeps treatment grounded in the client's needs and goals rather than our own assumptions about what is best for them. So starting with the evaluation, it's the first point of contact where we gather essential client history related to substance use, mental health, medical conditions, legal involvement, and family dynamics, and motivation for treatment. So some key questions is, what's bringing the client into treatment? What challenges or barriers are they facing? And what are their immediate and long-term needs? So if we're looking at John Doe, his evaluation showed a history of opioid and alcohol dependence, recent relapse, unmanaged depression, anxiety, and an unsafe living environment. And moving on to that psychosocial assessment. So usually that's that next point after the evaluation. The psychosocial assessment expands on the evaluation by applying ASAM criteria to determine risk ratings and guide placement decisions. So questions that we might ask ourselves is, how do clients' substance use, medical, mental health, social factors align with their ASAM's 6 dimensions? What risk ratings are justified based on clinical data? So for John Doe, again, his psychosocial assessment revealed withdrawal symptoms and a history of seizures. unstable mental health, high relapse potential, no safe housing. And again, this is going to validate ASAM recommendation for 3.7, or medically monitored inpatient care. And then when we're looking at moving from the ASAM to the treatment plan, once that ASAM placement's formed and completed, the treatment plan has to align with the identified risks and level of care. And that's where that golden thread is critical. Treatment goals should never come out of nowhere. They should be directly connected to what was identified in the assessment, the psychosocial, and the ASAM. The golden thread ensures that we're not imposing our own ideas of what the client should be working on, but instead we're developing a plan that connects back to the client's needs and goals, addresses the risks and challenges identified in the ASAM dimensions, and provides structured interventions that match the level of care. So again, some questions to ask ourselves. What goals and interventions address the client's specific risks? What structured supports would be provided at the recommended level of care? How does this plan help the client move forward in their recovery? Not what we think is best, but what are they here to actually work on? So an example for John Doe's treatment plan would be withdrawal management to stabilize symptoms, psychiatric evaluation and therapy to address depression and anxiety, relapse prevention and education and coping skill building, and case management for housing stability and sober living options. So in clinical settings, it's easy to fall into the trap of creating treatment plan goals that seem appropriate to us but don't actually reflect the client's needs, experiences, or priorities. The golden thread keeps us accountable by ensuring that treatment is client-centered, not clinician-driven. It's not about what we think the client should be working on, but about what brought them here and what they're ready to work on. It's grounded in real data, not arbitrary expectations. Goals and interventions should always connect back to what was identified in the evaluation, psychosocial, and ASAM assessment. And treatment plans are living documents, not a checkbox exercise. Treatment plans should be meaningful and adjusted as the client progresses, ensuring that they remain relevant and useful. And they should also be individualized to that client. Everybody's treatment plan should look different than everybody else's. And treatment plans are a tool for client engagement, not just a requirement. When treatment is rooted in the client's reality, they're more likely to engage because they can see how it connects to their personal journey directly. Without the golden thread, treatment becomes disconnected from the client. Goals and expectations appear out of nowhere, making them feel imposed rather than meaningful. Treatment then becomes about what we think is best instead of what the client needs and is ready to work on. So by keeping the golden thread intact from evaluation to treatment planning, with the ASAM just a stop along the way, we ensure that everything we do has a purpose and is genuinely aligned with the client's recovery process. And the last big thing that I want to talk about as far as ASAM goes is insurance documentation and considerations. So accurately completing the ASAM placement form is not just a clinical process. It does have that process that ties into that golden thread, but it also plays a crucial role in securing insurance approvals and funding and ensuring that clients receive continued access to treatment. Insurance companies use ASAM placement decisions to determine whether a specific level of care is medically necessary. Proper documentation can mean the difference between approval and denial of coverage, making it essential to provide clear, concise, and clinically justified information. Insurance providers rely on ASAM criteria to evaluate whether a client meets medical necessity for treatment. The more accurately and objectively we document a client's risks and needs, the stronger the case for coverage. So insurance companies are looking for a clear connection between risk factors and level of care, evidence that less restrictive levels of care are not appropriate, and justification for continued treatment at the current levels of care. So if a client is recommended for 3.5 residential treatment, documentation should show why IOP or PHP would not be sufficient. So you would say multiple past relapses and lower levels of care, severe withdrawal history, or lack of stable housing. And I think that we said all of that for our John Doe in 3.7. And insurance denials often happen when documentation is too vague. Like if you said client struggles with relapse instead of client has relapsed 3 times in the past month despite IOP participation. Or maybe risk ratings are too low to justify the recommended level of care, or there's no clear justification for continued stay or transfer to a higher level of care. So by aligning documentation with ASAM guidelines and risk ratings, we ensure that insurance reviews reflect the true clinical needs of the client, increasing the likelihood of approval. Throughout this training, we've covered key components of the ASAM criteria and how to use them effectively in level of care placement. Understanding and consistently applying ASAM ensures that clients receive the right level of treatment, that insurance approvals are justified, and that documentation remains clinically sound. So let's recap some major takeaways. ASAM's 6 dimensions help assess clients' medical, psychological, and social needs, providing a comprehensive framework for substance use disorder treatment decisions. Levels of care range from outpatient to medically managed inpatient, ensuring that clients receive just the right amount of support without unnecessary restrictions. Risk ratings, or that 0 to 4 scale, help determine severity and treatment needs, but do not automatically dictate level of care. Clinical judgment and full assessment across all dimensions are essential. Documentation matters. Use clear, concise, and professional language to support treatment recommendations and ensure insurance approvals. You don't have to write a whole book in each dimension. but you do have to justify why that level of care is needed and why lower levels of care are not. And that golden thread connects evaluation, psychosocial assessments, ASAM placement, and treatment plan, ensuring consistency and client-centered care instead of arbitrary treatment goals. So some final reminders. Talk to your supervisor or peers when uncertain. ASAM placement decisions are complex, and collaboration ensures accuracy and appropriate recommendations. Apply ASAM criteria consistently. This prevents overplacement or underplacement and ensures that clients receive least restrictive, most effective levels of care. And use those resources, that CareLogic cheat sheet under Test Client or Client 2572, dated July 12, 2022, and the ASAM binders on site at JADE provide clear guidance on criteria for each level of care. By using ASAM effectively, we ensure that treatment remains clinically appropriate, client-centered, and supported by strong documentation. Thanks for your time, and let's continue working together to provide high-quality, individualized care for the clients that we serve.